Instead of sorry, I took a bit of time. Okay, so we should start again. Okay, so everybody is back. Oh, so there's some chats, questions in chats. Okay, so we're going to start now. Are we okay to start now? Okay. Okay, good. Okay, so we still have the same number of people. Okay, so I hope not to take too long for the second one, which is basically, just turn this off. Okay, good. So we'll start off with the second part of the talk, which shouldn't be long. I promise to finish by 10:30 the latest. Okay. So similar problems. So you're going to see somebody like this in the next few hours. Some of you are on duty. Some of you maybe tomorrow. Okay. Comes to you with sudden onset of vertigo and vomiting, and then you see something like that. And then you're wondering, what could it be? Various thoughts will come to your head. Is this vestibular neuronitis? Is this cerebellar stroke? Is this benign positional proximal vertigo? Now, many of you are taught to diagnose these conditions diagnose these conditions, but we want to make sure that you have some sort of a foundation. So, like what we said earlier, because dizziness is also a complex problem, correct? So there must be a questions also. There must be a formula also. So the formula is based on 4 basic questions to ask. Okay. So first question you must always ask when a person comes to you for dizziness, okay, is whether the person's dizziness is a problem of balance and loss of balance and associated symptoms associated with it, or is it a sensorium problem? Now this is very, very, very crucial, because if you realize that it's a sensorium problem, it's a sensation of syncope. You're going to just faint if the dizziness continues, lightheadedness. The pathology is very, very different. The pathology has got to do with transient hyperperfusion of the brain. Transient hyperperfusion of the brain. Now, but on the other hand, if it's a problem of balance and nausea, vomiting, and all these things, then we know it's got something to do with your vestibular system or its central nervous system connections. So 2 different pathologies. So you need to try your best to ask the first question, whether it is a feeling of vertigo or is it a sensation of faint. Okay. So what is a simple definition of vertigo? So many of you would have experienced physiological vertigo. So when you are a child, you spin on yourself or you run around a tree or something, and then you stop, you feel yourself spinning. That is vertigo. It's almost always associated with a spinning feeling, but sometimes it may be a tilt sort of feeling. But very important, a very, very important point to remember is vertigo is almost always associated with nausea and vomiting. At least nausea, but usually vomiting. So please ask this question. Okay. Now, on the other hand, a sensation of syncope is what? Transient hyperperfusion of the brain. So I feel lightheaded. You know what's happening? I can't see very well. I can't hear very well. Oh, before I know it, boom, I'm on the floor. That is syncopal feeling. So that syncopal feeling is quite different from the vertigo feeling. But the challenge is trying to persuade your patient to translate in whatever language that they're speaking to and tell you what they mean. Okay. Now, I often find it useful to tell the patient, please describe to me as if you're describing the symptoms. Don't use technical terms. Try to use, don't just say I fainted. Okay. But what exactly happened? Oh, I felt lightheaded. I couldn't hear myself very well. Sounds were getting more and more distant. Vision was getting a bit more blur. And I was losing my balance. And before I know it, I was on the floor. Oh, no, actually everything was going round like a mulberry bush, you know, going around the mulberry bush sort of feeling, or on a feeling of being on a merry-go-round, you know, spinning very fast. And then I was vomiting everywhere and I couldn't open my eyes. I just had to lie down. So straight away, this tells you whether these are two good patients who are describing to you sensation of syncope or vertigo. Okay. Now, I'm going to cut to the chase and go straight to this part first. Sensation of near faint or syncope. Sensation of near faint or syncope, which usually I do at the end, but this time I decided to do it earlier because I just want to get it out of the way quickly. Okay. If the patient says, doctor, I'm not vomiting, I'm not nauseous, things are not moving around me, but I feel like I'm losing touch with the surrounding. Okay. Then we are dealing with a syncopal feeling. Now, syncopal dizziness has only one pathophysiology, this. Now, why is this important? Because once you understand that, you can easily figure out what is going wrong with the patient. Why is it so easy to figure out? Because you think about it, what could cause transient hyperperfusion of the brain? Well, there are only a few things that can go wrong, and it's all in this chart. Because blood starts from where? From the heart. So the problem could be in the blood pump itself. The pump is not working. Why is the pump not working? The patient has heart failure, the patient has hokum, the patient has aortic stenosis, some form of problem with the flow. So whenever he exerts himself, he's feeling syncopal. So that is an important cause of cardiac syncope, outflow problem. But a more common cause, often seen in emergency department, and many of your emergency doctors are experts at this, is cardiac dysarrhythmia. How do cardiac dysarrhythmia present? The heart is beating regularly, suddenly it either fibrillates or it slows down and stops for a while, like a heart block. During that time, blood is not flowing to the brain. What's the patient going to feel? Patient is going to feel like, oh, I'm going to faint. Next moment, it's on the floor. And compared to standard sort of fainting, vasovagal fainting, this one will be sudden and unexpected. So always look at that cardiovascular system as a cause. So once you think about it, you're not going to go wrong. So you'll examine the heart carefully, take the blood pressure, examine the heart carefully, listen for murmurs, do a ECG, look at the PR interval, look at the QTC interval, look for any evidence to suggest that this patient's episodes of dizziness could be due to a cardiac cause. Now, once you've done the checklist, this is the checklist again. Once you've done the tick for the first part of the checklist, the next in the checklist will be blood itself. The blood pump is working, but maybe the blood is abnormal. So what could go wrong with the blood? Many, many things. Hypoglycemia, hyperglycemia, anemia, polycythemia, hyponatremia, hypercalcemia, all these general medical causes. You know, those of you who are physicians in the audience will know many, medical patients come to you with hyponatremia and they'll say, tau, doctor, tau, him, tau, gong, gong, tau, boo, boo. Correct? Right? And then you realize sodium is 118. Okay? So, again, the checklist will save you. Look at the heart, carefully from the pump point of view and the rhythm point of view. Quickly look at the blood, look at all the usual blood things that can go wrong from hypoglycemia all the way to anemia. And then you can go on to the next thing, which is blood pressure. Okay, blood pressure means the pump is working okay, the blood is okay, but somehow the pressure is not being transmitted to the brain. And usually low pressures, okay, when they come to the emergency setting, can be either due to persistent hypotension, for example, bleeding GIT or overuse or shock or something of that sort, or more commonly in the medical patients, it will be episodic low pressures. The episodic low pressures are usually due to drugs or autonomic failure. In the emergency setting, very easy. Just ask your nurse to quickly do a blood pressure measurement, standing and lying, okay, using a Dynamap electronic set, which gives you simultaneous heart rate and blood pressure monitoring. Now, so once you have ruled out all these causes, then you have to start thinking about whether it could be the blood vessels. Okay. Now, I must say that blood vessels, because we have 4 blood vessels to the brain, 2 carotid arteries, 2 vertebral arteries, and then they form together and party together in the brain called the circle of Willis. Okay. So very rarely do blood vessel problems cause the patient to faint. Okay. Most of the time, blood vessel problems cause what? They cause TIAs. Okay. They don't cause actual fainting spasms because of the redundancy. Okay. So occasionally you get a patient with the posterior circulation, the vertebral basilar artery, that gets thrombosed or narrowed, and the patient loses consciousness from posterior circulation stroke, but not common. Okay. Then finally, in this checklist, so blood pump, blood pressure, blood vessels. Finally, you come to the checklist for blood vessels. Blood vessels means it is a benign disorder called vasovagal syncope. Now, this is very common in the emergency setting. Okay, vasovagal syncope is a benign disorder where, due to a predisposition in the patient and due to noxious stimulus coming from outside, the patient has an unexpectedly stressful response by reducing the blood pressure and reducing the heart rate. That's why it's called vasovagal. And during that period, if the person is standing or sitting, the patient is going to lose consciousness. But the moment the person falls on the ground, the hydrostatic pressure ensures that the blood is transmitted to the brain, the patient wakes up. So almost always vasovagal patients will have a few characteristics. Number one, they will have a long history of repeated episodes. They wouldn't come to you at 90 years old and say, oh, my first time I'm fainting from vasovagal syncope. They would have fainted when they were in school assembly. They would have fainted when they got bad news at workplace. They would have fainted when their wives were delivering in KK and the baby is coming out through the perineum. They would have delivered when they were when they would have fainted when they had bad news at the workplace, when the boss sacked them, and then they would have fainted when they were elderly men, when they are pressing, trying to get their urine out through a prostate that's enlarged. Okay, so this is an autobiography of a fainter. Okay, so you wouldn't, so it's quite consistent history of fainting throughout the life. Then you're quite happy to call this faints benign vasovagal faints. But if somebody 90 years old comes and says, first time I fainted in my life, or I'm having vasovagal syncopal episodes, sorry, not vaso, syncopal faint giddiness episodes, then you have to think about blood pump problems, blood pressure problems, blood problems. Okay, and not label it as vasovagal. But if somebody who's young, who's got many episodes in the past, and usually the episodes are very stereotypic, almost always must be standing or sitting, cannot be lying down, because when you're lying down, the blood pressure will never drop to the point where the patient faints. Okay. Secondly, the patient will have a premonition. It will not be super sudden. There will be a build-up. You will feel a bit lightheaded, and if you took precautions like quickly lie down or massage the patient or just have a hot drink or something, the patient will recover, right? But most of the time, the good Samaritans are the ones who are coming and holding up the patient and causing the patient to faint. Okay, and almost always when they are falling, they start regaining consciousness as they are starting to come into a supine position. So almost always should not have fractures, because they will brace themselves. They shouldn't lose continence also. Okay, incontinence shouldn't be there. Okay, and finally, when they lie down on the floor, they almost always will regain consciousness. Okay, they may not open their eyes, but they will start hearing people calling them. They will hear the paramedics calling them. They will hear their colleagues coming for their assistance. Okay, so they will never be unconscious. So remember that. Okay, so Very quick summary now. Okay, whenever you think a person has transient hyperperfusion of brain presenting a recurrent syncopal dizziness, think about first the pump. The pump could be a problem in the heart itself, okay, the flow or the rhythm. Okay. If not, it could be in the next part of the checklist, it could be something wrong with the blood. Okay, in the blood, there are a number of things that I often have. I carry a small checklist and I go through: anemia, polycythemia, hypocalcemia, hypercalcemia, hyponatremia, hypoglycemia, sepsis also in the elderly. Yeah, so all these are causes of syncopal sort of dizziness. Okay, now once you've gone through these two checklists, then the next part in the checklist would be blood pressure. Okay, hypotension, which is either persistent in patients in shock or episodic, like due to drug-induced orthostatic hypotension from postural hypotension. Now, rarely it's due to blood vessels, due to posterior circulation TIA, and only after you've done all of that, then you start thinking about vasovagal syncope. In vasovagal syncope, the classic features will be previous episodes in the life, okay, no severe injuries because of the fall. Often there's a premonition preceded by noxious stimulus, almost always in a sitting or standing position. In fact, those of you interested may have come across this literature that actually the vasovagal syncope is actually a phylogenetic remnant of an evolutionary play date phenomenon. Okay, but I won't go too much into it. But basically, our mammalian cousins and our ancestors it was beneficial for them to play dead when the threat to their life was tremendous. So they lose their blood pressure, they lose their heart rate, and they go into a state of suspended animation. And that makes the animals the predators avoid them and walk away and gives them a chance to survive. But that was an evolutionary trait that we had. But for us humans now, it's a bit of a nuisance because our heart has gone below the brain. So remember, when you're four-legged animals, the heart and the brain are in the same level. So it only comes on when the stimulus is very, very severe, when the lions are a pride of lions are surrounding you. Yes. But here, because our heart has gone below the brain, or the brain has gone above the brain when we stand, that's when it's become a nuisance. So this is not a disease. Now remember, vasovagal dizziness or vasovagal syncope, vasovagal is not a disease. It is a normal physiological reflex, and patients should be taught how to manage it. Okay? Okay, any questions at this point? If no questions, then I'm going to go back to the first question again, which is basically, what if the dizziness was not a syncopal? The first question, right? It is, doctor, no, I'm not losing consciousness. I'm not having a syncopal episode. I'm completely conscious when I'm spinning like crazy and I'm vomiting all over the doctor. I vomited. Okay, so that's vertigo. And we already said vertigo means rotatory movements with nausea and vomiting. So once you've decided this patient has got vertigo, the next question you need to ask yourself is the vertigo peripheral or central in nature? And for that, actually, the life is fairly straightforward. Why? Because we know in the central nervous system means the peripheral vestibular system is not isolated in the central nervous system, right? It has got lots and lots of buddies hanging around him. Who are the buddies? Your cranial nerves. Cranial nerve 3, 4, and 6 will cause double vision. Cranial nerve 5 will cause numbness of the face. Cranial nerve 7 will cause weakness of the face. 9, 10, 11, 12 will cause dysarthria dysphagia. Okay? So if the patient says, doctor, while I'm spinning, I'm getting double vision. While I'm spinning, I'm having numbness in my face. While I'm spinning, I'm having swallowing and speech problems. When I'm spinning, my right side of my body or my left side of my body is not moving, or my right side of the body or left side of the body is numb. So straight away, that tells you this must be central in nature. Central in nature. So look for associated symptoms to rule out whether it's central or peripheral. Now, occasionally, you face with a patient who has got none of these. That means the doctor, I'm spinning like crazy, but I've got none of this. I've got no double vision. I've got no numbness of the face. I've got no weakness of the body. I've got no dysarthria dysphagia. Nothing. Then you have to look a little bit harder to make sure that you're not missing a central disorder. Okay. So the first thing we do is look for the type of nystagmus. Okay, type of nystagmus. Is the nystagmus peripheral in nature? Okay, now to peripheral nystagmus is unidirectional, meaning that it doesn't change direction. Okay, it always beats in the same direction. Okay, and the fast phase is away from the side of the pathology is often mixed horizontal and rotatory. Okay, now many of you will be looking at this and say, how am I going to remember this? Okay, so to do that, I'm going to give you a very simple method of trying to remember it. Okay, so for that, I need you to pay attention to me. Look at my face. Okay, I should look here, right? I should look at the camera. Look at my face. So while I'm looking at you guys, I'm turning my head left and right, right? While I'm turning my head left and right, my eyes are still fixated on you. Of course, I could do it consciously, but we have a reflex called a vestibulo-ocular reflex that allows me to continue to look at you, even though I turn my head this way. Turn my head this way, I'm still looking at you. Okay? Unconsciously, I'm still able to look at you because of the vestibulo-ocular reflex. The vestibulo-ocular reflex works because I've got semicircular canals here and semicircular circles, semicircular canals here. There are two sets of semicircular canals. They're going to pick up the movement, okay, and tell the brain where my head is moving. So when I turn my head to the left, my semicircular canals on the left side, the fluid inside the semicircular canals on the left side will start moving. Okay, because they are full of fluid. So when I move my head this side, this one will start moving. Okay, this signal is then sent to opposite 6 nucleus, the opposite 6 nucleus here. Okay, and my right eye will abduct and left eye will adduct. So notice, that's it. It's not so difficult. Once you do this vestibular dance, you can figure out this easy reflex. You don't believe? We can do the other direction now. I turn my head to the other direction. Which vestibular system was active? My right semicircular canals, the fluid started moving because when you move, the fluid will swish within the semicircular canals, right? So the fluid is swishing. So the fluid swish in the semicircular canal. This signal is then sent to my contralateral 6 nucleus. Okay, my left eye, notice my left eye is abducted. My right eye adducted. Okay, so this is the vestibulo-ocular reflex. Okay, so when I turn my head to the left, my left eye, my left semicircular canal is active, my right eye will abduct, left eye will adduct. When I turn my head to the other direction, my right semicircular canal is active, my left eye will abduct, my right eye will adduct. Okay, so that's the vestibulo-ocular reflex. Now, don't look at the slides here, just continue to look at me. Now, on the rest position, both semicircular canals are at rest position. Now, if I get an acute vestibulopathy, like an acute vestibular neuronitis, okay, let's say I damage my left semicircular canal, it's completely dead. Okay, it's completely dead now. Now this guy is still firing, correct? This guy is still firing. This guy, remember just now both were firing. Now this guy is completely damaged now. This guy is firing. Now this, as far as the brain is concerned, this firing now is going to simulate what activity? My head turning to the right. Remember when I turned my head to the right, this side was firing more. When I turned my head to the left, this one is firing more. Now, even though my head is not turning, because this side is dead because of vestibular neuronitis, this guy is firing at basal rate, the brain is going to think that my head is turning to the right. Correct? So the brain is going to think that my head is turning to the right, and my eyes are going to move as if my head is turning to the right. So when my head is turning to the right, what happens? My turning to the right. My left eye abducts, my right eye abducts. Correct? My left eye abducts, right eye abducts. Correct? So that's exactly what will happen. So this side is damaged. Okay? This guy is active, so my eyes will start drifting towards the left. But then now I'm thinking I want to look at you through the zoom camera, right? So what must I do? I will try to, my eyes are deviated towards my wall. So what do? I'll bring it back. But the moment I bring it back, my imbalance is still, this guy is still too active. He's going to push my eyes towards the left. Then I'll bring it back. Okay. Then this guy is still active. He's going to push it back. Then I bring it back again. The imbalance still pushes my eye towards the left, and I bring it back again. The imbalance still pushes my eye towards the left, and I correct it back to the center again. So what do you think is happening now? What am I simulating to you? I'm simulating nystagmus, right? Yeah. And where is the direction of nystagmus? Remember that my left ear was damaged. My direction of nystagmus is towards the right. So right beating nystagmus. Now this nystagmus direction, will it change? No. Whether I look up, look down, look left, look right, the imbalance is due to one ear being damaged, the other ear being normal. So the nystagmus direction will always be unidirectional. Unidirectional. And those of you who want to go further in depth into analysis of this and understanding your clinical signs of the patient, you realize that the fast phase is beating away from the side of the disease. The left ear was diseased, right ear was active, pushes the eyeball to the other side. My correction is poop, away from the disease. Okay? And then because the semicircular canals are positioned in this way, now the way it's positioned will allows you, this is damaged, this is still active. Now the semicircular canal from the top and the bottom semicircular canal, superior and posterior semicircular canal will cancel themselves out. The semicircular canal that is not cancelled out is the horizontal semicircular canal. And therefore, you're not surprised that the nystagmus is predominantly horizontal. So the vestibular dance now has allowed you to work out the basis of peripheral nystagmus. I hope this is important. You take home this message, because if you try to memorize this, I can promise you tonight you'll forget. Okay, but if you just remember what I just told you about the semicircular canals and you do the vestibular dance, okay, the fluid moving within the semicircular canal, stimulating the eye movements, and how when one side is damaged, the other side pushes the eye to this side, and then there's a corrective movement. You realize that peripheral nystagmus firstly cannot change direction, must be unidirectional, always be in the same direction, no business to change direction. Okay, that is the most important. That's why I put it in front. The rest of it you can work it out using the vestibular dance I told you. But the most important thing for the emergency doctor is unidirectional, doesn't change direction. Okay, so this is a good example of a patient with you notice there's a little bit of nystagmus to the right, but when he looks to the right, he's beating more to the right. He's much more severe when he looks to the right. But when he looks to the left, it doesn't change direction. It still beats the right, much less. But the important thing is it doesn't change direction. Doesn't change direction. Now, one of the minor points that I didn't explain to you because your interest is to quickly sort this out and move on to the next patient. You don't have to worry about all the details of analysis of this patient. So I didn't talk. But one of the things about peripheral nystagmus is like a Romberg sign of the eye. When you close your eyes, you fall. If it's a peripheral pathology, Romberg's is positive in your limbs, right? So the same thing for nystagmus also. If it's a peripheral nystagmus, the Romberg sign is positive. You close the eyes, the nystagmus gets worse. Okay? So you notice here, when he closes his eyes, his nystagmus is much worse. So you can try that. Try to gently close the eyes. Some patients, the lids are thin enough for you to descend this. See, the nystagmus is so much more obvious. When his eyes open, nystagmus, very difficult to pick up. Very much. But once you close the eyes, boom, 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 boom. Okay, so you can try that. Now, many of us, because if the eyelids are very thin, you cannot just rely on eyelids alone, right? If the eyelids are thin, you can. So we use this thick magnifying glasses to take away visual fixation. So notice with the visual fixation removed, basically by putting magnifying glasses, the patient can't see. Okay, so you are seeing that the nystagmus gets worse. Nystagmus gets worse whenever she's wearing the glasses. When vision is normal, she can see the nystagmus disappears. So this is Romberg sign of the eye. So you could do that if you have the glasses, but otherwise just ask the patient to close the eyes. But the most important point for you is this. The nystagmus cannot change direction. Okay? Okay. Now, as opposed to central nystagmus, where the pathology is not due to imbalance in the inner ear, it's due to cerebellum and brainstem problem, where the nystagmus always changes direction according to where you're looking. You look to the left, it beats to the left. Look to the right, it beats to the right. Okay? So I'm very sure now you are not going to make a mistake with this patient. This patient who comes to you with vertigo clearly must have central disease, because when she looks to the right, the nystagmus is beating to the right. When she looks to the left, straight away the nystagmus changes direction and starts beating towards the left. On the right, it's beating to the right. On the left, it's beating towards the left. Okay, so nystagmus, the changes direction is central. Likewise, this patient, nystagmus, when he looks to the right, he's got Wernicke's encephalopathy, another important condition in emergency setting. We give them large amounts of timing to save them. Okay, you notice his beats to the right. When he looks to the left, it changes direction. Now he's beating to the left. So this clearly is central. Okay. Now, so as I said before, look for central features to diagnose central vertigo. Central features like diplopia, numbness of the face, numbness of the weakness of the face, swallowing problems, speech problems, weakness of the limbs, numbness of the lips. Okay. Now, if there is nothing like that, look carefully at the nystagmus and see whether it is peripheral, meaning it's unidirectional, never changes direction, or is gaze evoke. That means look to the left, beats to the left, looks to the right, look to the right, beats to the right. Okay, trying to figure out whether it is change direction. Okay. Now, some of you, the seniors in your group, will be trained to do the head thrust sign. So call them to help you with the head thrust sign. Okay, and if the head thrust sign is positive, it is suggestive of peripheral nystagmus, peripheral vertigo. If the head thrust sign is negative, it's a central disease. Okay, this is difficult to teach you how to do a head thrust sign in a Zoom video, but your seniors will know how to do it. But I'll show you this patient who has got a very clear head thrust sign that even if you don't know anything about the sign, you will pick it up. Okay, so normally we move the head very slowly, gently left and right to reassure the patient, and then we thrust the head to the right. Thrust the head to the right. Now we thrust the head to the opposite direction. And then some of you would have noticed there's a difference. What's the difference? Well, now the patient's instruction was to look at the doctor all the time. So you notice that the patient is looking at you all the time, correct? So when you thrust the head to one direction, the eyes are still fixated on you. But when you thrust the head to the opposite direction, the abnormal direction, suddenly for a few moments, the eyes are not looking at you because the eyes are following the head. Because there is loss of vestibulo-ocular reflex, so she cannot automatically look at you. She has to do it voluntarily much later when the head comes to a stop. Okay, so let's run it again. So this is slow movement just to reassure the patient, and then after that you do the head thrust. So start from the center, push to the right, normal. Normal. She's still looking at me. Now I'm going to the abnormal side. She's not looking at me. She's not looking at me. So abnormal head thrust to the left. So she has left vestibular pathology. Okay, you notice that she has to voluntarily remember, the instruction was to look at the doctor. After the head has stopped, she turns and looks at you. So that is a positive head thrust. Okay, very easily contrasts with the normal side. Huh? So to the right, she's looking at me. She's looking at me. To the left, she's not looking at me. She's not looking at me. So abnormal left head thrust. So that's head thrust sign. Okay. So head thrust sign is an important sign that your seniors will know how to do it. And then finally, there's one more, slightly more sophisticated sign called a skew deviation, which your seniors know also. But for you, you should focus on the key things, which is symptoms and signs of dysfunction in the cranial nerves, symptoms and signs in the upper and lower limbs suggestive of central nervous system pathology. Okay. Central nystagmus, which is gaze evoked nystagmus. Okay. Now, what is skew deviation? Your seniors will tell you, will look for you, will teach you how to do it in bedside teaching. But basically, when you sit the patient up and ask the patient look forward, one eye seems to be at a different plane from another eye. One eye is high, one eye is low. So this vertical deviation of the eye is called skew deviation. Okay, this is again a sign of central disease. Now, don't worry, you're not expected to do to look for this, but your seniors will do this. When they do this, then they will come up with this. They will often use the word hints because in the hints protocol, head impulse, nystagmus, and skew deviation. These are the three additional features that will tell us whether we are dealing with central or peripheral disease. For medical officers, most of the time you'll focus on symptoms, signs of cranial neuropathies and limb coordination, and look at the nystagmus. Okay, the additional HI and the skew deviation, your seniors will know how to do it, and that will give us a clue of whether we are dealing with a central vestibular disorder or a peripheral vestibular disorder. Okay? Okay, so that was the second question. Remember, we spent a lot of time on the second question because once you've decided it's vertigo, the most crucial question is it peripheral vertigo or central vertigo? And we went through all the steps. In summary, basically, is to look for associated signs of central disease. And if you are getting more and more experience, try to discern the type of nystagmus, and your seniors will teach you how to do the head impulse and skew deviation to decide whether the vertigo is central or peripheral. Okay. The third question is duration of vertigo, because the duration of vertigo is few minutes only in benign positional paroxysmal vertigo. It's many, many, many hours in vestibular neuronitis. It's variable in posterior circulation stroke. For migraine, which can present sometimes with vertigo, is many, many hours. Okay. And the last question is whether this vertigo is the first episode ever or is it a recurrent spell. Okay. If it's the first episode ever, then you're not sure because it could be the first episode of a recurrent spell or it could be a monophasic illness. But if it's a recurrent episode, then we know recurrent vertigo is either benign paroxysmal vertigo or posterior circulation transient ischemia. That means the ischemia in the cerebellum or the pons or the medulla or the midbrain, but it's not going on to a stroke. It's threatening to patient presents vertigo and goes away. Vertigo goes away. Vertigo goes away. Okay, so or migraine. These are the recurrent spells. On the other hand, if the person has only one episode ever in his life, then the two diagnoses considered is stroke, posterior circulation stroke in the cerebellum, pons, medulla, midbrain, or vestibular neuronitis. Vestibular neuronitis never recurs. Okay, so it is a common mistake to say that it's recurrent vestibular neuronitis. Vestibular neuronitis is a monophasic illness. Okay, sudden onset of vertigo with nausea, vomiting, lasting many hours. Okay, that's vestibular neuronitis. Okay. Okay. So monophasic illness, think about stroke and vestibular neuronitis. Recurrent illness, think about BPPV, and the characteristic feature of BPPV is very short spells. If the patient can tell you how long the actual spinning lasts, they will tell you it's lasting less than 2 to 3 minutes. Okay. Posterior circulation TIA can be recurrent, but the recurrence cannot be chronic because TIAs can never be chronic, right? I cannot have recurrent numbness or vertigo associated with posterior circulation disease that's going on for the last 5 years. I can't. Because what will happen? The blood vessels either narrow and go on to become a stroke or they resolve and the patient is better. Okay. So general principle is if the person has got recurrent spells of vertigo, especially with associated neurological symptoms in the last 3 to 6 months, then you have to consider posterior circulation TIA. But somebody who's got multiple short episodes of vertigo that's lasting many years, 5 years ago I had one spell, 3 years ago I had another spell, then we are most likely dealing with either benign positional paroxysmal vertigo where the spells are very short or migraine vertigo where the spells are very long. Remember we talked about migraine earlier on. Migraine is mainly headache with nausea, vomiting, and some dizziness, correct? But the headache is prominent. Occasionally, patients will come and tell you the headache is not so severe this time, but the vertigo is prominent. That's why migraine still comes into the equation when it comes to vertigo. Okay, now in the last few minutes, we will go through a few case scenarios and then we're done. Okay, those of you who need to leave, please go ahead and feel free to leave. Okay, because It's 10:30 already. Okay, but I'll quickly put the 4 questions together. So, doctor, I'm a patient coming to you. Okay, we'll start with Jessica. Okay, Jessica, do you want to give it a try? Jessica, you. I'm going
Yeah.
to. Okay.
Hello. Yeah.
Okay. So, doctor, I'm a patient coming to you. I'm feeling very, very giddy, and my giddiness is spinning in nature, and I'm vomiting all over. So, first question answer would be vertigo, right?
Yeah.
Okay. What's the next question you want to ask?
Whether they are to localize between CNS versus peripheral.
Good. And then, doctor, you are very, you are well trained, doctor, because just as I got this vertigo, I started developing double vision. My right side of my face is numb. My right side of my body is weak. So I have central features, correct?
Yep.
Okay. What's the next question you want to ask? Whether it's recurrent
Uh,
or monophasic, correct?
yep.
Yes. Okay, yes, you're right. The last 3 days, I had multiple spells, each spell lasting about 1 to 2 hours. It disappears, it comes back. The last one has been lasting for the last 4 hours. Okay. And it's the last question is how long is the duration of each attack? It's lasting many hours. So what's the diagnosis for this? Only one diagnosis, right?
Uh, we rule out TIA. Sure.
Yes. So this patient needs to be admitted as far as you're concerned. Don't waste time with scans. Don't waste time with CT scan. Don't waste time with that. Just admit the patient. Really, the pre-test probability of this being a TIA is so high that nothing you can do to convince anybody in the emergency department that this is not TIA, correct? So you might as well admit the patient. Don't waste time observing the patient. Don't do CT scans for this patient. Don't do all this. Just admit the patient. Okay? Good. Okay, next one. Um, who wants to be a volunteer for the next one? Samuel. I see Samuel. Are you there? Or you fell asleep or you just turn it on and doing your things? Samuel, I can't see your last name though.
Hi, Prof.
Yeah, Samuel. Okay, don't worry. I'll make it easy for you. Okay, so the first question again, I'm a patient coming to you and I'm saying, Doctor, I'm spinning all over. Okay, and I'm vomiting. I'm very prominent nausea. So it's not syncopal dizziness, it's vertigo dizziness. So first question is answered. The next question is whether this got I have central or peripheral features, right? Okay. So what are the questions you will ask me? We might have mentioned earlier. Go through the cranial nerve checklist and the limb checklist. So for 3, 4, 6, ask for double vision. 5, numbness of the face. 7, facial weakness. 9, 10, 11, 12, dysarthria dysphagia. In the limbs, weakness, numbness. I'm the patient and I'm telling you, I'm Dr. Samuel, I got none of these central features. Next question is, Dr. Samuel, next question.
First of recurrent episode.
Yes, is this my first episode, doctor? I'm for 54 years old, first episode in my life. And it's lasting many, many, many hours.
Yep. So this sounds like a presentation of vestibular neuronitis.
Good, very good, because vestibular neuronitis is a monophasic illness lasting many hours and it can occur in any age group. But where is the cognitive flaw here? Vestibular neuronitis is absolutely correct, but you need to have a differential diagnosis. The cognitive flaw here is that your second question is actually not conclusively answered, right? It's got no CNS or peripheral features, right? So can it still be a stroke? I'm a 55-year-old smoker, diabetes, high blood pressure. So I could still be stroke, correct? Right? So it can be vestibular neuronitis or posterior circulation stroke. Just because I don't have any central nervous system features doesn't mean it cannot be a stroke. Because remember we said sometimes the patients with a posterior circulation stroke will only have an abnormality in the HINTS. Okay? So you are right, vestibular neuronitis is the first diagnosis to consider as a medical officer, but you would have to call your seniors and tell them, look, I don't think, I have not found any central nervous system features. I think it's vestibular neuronitis, but can you help me rule out central nervous system pathology? And they will say, yes, no problem, Dr. Samuel. I will do the head impulse test. Head impulse is negative. Skew deviation is negative. Okay, skew deviation is negative. Okay, then what will he say? Heat impulse is negative. Uh, Heat impulse is negative. Heat impulse should be positive or negative in vestibular neuronitis?
Should be positive.
Should be positive.
Right.
So then you will say heat impulse negative in a patient with suspected vestibular neuronitis is not consistent with vestibular neuronitis. Please admit the patient for further evaluation. On the other hand, he comes and does a heat impulse positive. Peripheral nystagmus. Nystagmus is classically non-direction changing, unidirectional. No skew deviation. That means all the HINTS criteria is satisfied for vestibular neuronitis. So you will say, please give the patient some mild vestibular sedatives, 3 days of medical leave, and go home. Okay? You understand, Samuel? Yeah. So, but of course, as you get more and more mature, you'll be able to start doing all these signs and you'll be able to sort it out. But the point I'm trying to make is that in posterior circulation disease, the absence of central nervous system features is not enough to rule out posterior circulation stroke. You need to do those additional tests. So if you're not trained, you just call your seniors to come and do it. Okay, and they will do it for you. And if the head impulse sign and the skew deviation sign points towards peripheral disease, then you're right. This is vestibular neuronitis. But if it points towards central disease, then the patient needs to be admitted for evaluation. Okay, I hope you're clear about that. Huh? Okay, next common scenario. Aline Ann, can you help with that? As you can see, I just need somebody to help me. I'm giving you most of the answers, so don't be frightened. Aline Ann, can you join me? Right now, any volunteer? Or shall we just ask Samuel to continue? Samuel, can you continue?
So
okay. Okay. The next scenario is very simple also. Again, a patient who comes to you, doctor, I'm vomiting all over.
Yeah.
I'm spinning all over and I'm not having a syncopal feeling. I'm not having a loss of consciousness feeling. I'm spinning and I'm vomiting. So it's definitely vertigo. And then you go through all the CNS peripheral features like just now and everything is negative. Okay. But this time I say, doctor, but this is recurrent, no, doctor. You know, I'm 55 years old now. And when I was 50 years old, I went to Kutekpo Hospital for a similar episode. When I'm 53, I went to SGH for a similar episode. Since it's I can't travel during COVID period, I decided to tour the hospital. So I decided to change hospital, I'll come to you this time. Okay. So this time also similar episode. So it's recurrent. And each episode is very short, no. Because by the time I want to quickly show the doctor what's happening, the swell disappears. And every time seems to happen when I lie down in bed, when I put my head back. The moment I put my head back, lying down, pop, the spinning comes. And then I quickly call for help. My family members come. But once they get me up, when they come, it's all gone. So they sometimes don't even believe me. So what is the most likely diagnosis here?
It's a case of BPPV.
Very good. Now this story is very typical. But again, BPPV diagnosis must be confirmed with the supine head roll test and the supine head roll test and the Dix-Hallpike test. Okay, we have some videos of it here somewhere. Okay, which I'm not going to show you today because we don't have time. But your seniors are trained to do that. Okay, so call them and they will come and do the Dix-Hallpike test. Sorry, I can't find the video now. But anyway, I'll be sending it. It's in my notes. If those of you want to learn how to do it, those of you who are going to become professional ED physicians or internists, you need to learn how to do it. It's in my notes. I've linked it. So here you would go on and do the Dix-Hallpike maneuver. Okay. You do the Dix-Hallpike maneuver and confirm that this patient has got benign positional proximal vertigo. Okay. Because if there is no Dix-Hallpike maneuver is negative and supine head roll test is also negative, then you have to start thinking in an elderly patient with multiple risk factors and the duration of recurrence is only in the last few months. Samuel, what is the differential diagnosis?
It could be recurrent TIAs.
Yes, yes. So the key feature is it recent or very long? If the person has been having for like what I said, 50 years old, I had one episode, 52 years old, I had another episode, 53, another episode, now I'm 55. Then it cannot be a TIA because why should TIA recur so many times in the same territory without going on to develop a stroke or without resolving? So then it's BPPV. But if I say in the last 3 weeks, I've been having many short spells like this, and the Dix-Hallpike is negative, your seniors come and do it, then please admit the patient for TIA workup. Again, don't waste time in the ED, just admit the patient. Because when I teach ED doctors, I always tell them, you must clear your observation room, right? So just quickly admit the patient. No need to observe. Okay? Okay, good. Samuel, let's do the last one. Very easy also, last one. Okay, this is a person who's got vertigo, for sure again. Again, no central or peripheral system. Recurrent, but it's lasting many, many hours and many, 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 many years. Okay? Now, you often see this in emergency department. Okay? And these are patients who have otherwise typical migraine. Okay? If you ask them, they will satisfy criteria for headaches. Also, they will also have headaches that will satisfy criteria for migraine. So remember that as a problem. But if it's been but migraine, as I said before, like when we talked about headaches, it has to be something that started at a very young age. It's been going on for many, 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 many years. Correct? Now, if it's an elderly person who never had migraines before, and this has been going on for the last few hours, again, Samuel, you have to think about
Yes, TIA.
TIAs again, and you will admit the patient again. Okay? So, you realize that the 4-question approach, is very useful because firstly, the first question, if you decide is syncope, you go straight to the syncope algorithm. In the syncope algorithm, you have a checklist: the heart, the blood pressure, and the blood vessels. When you have ruled out all these things, ask yourself, could this be vasovagal syncope, which is benign? If it is not a syncopal dizziness, then if it's a vertigo, then ask yourself, second question is there any CNS features? Okay, and go through the checklist of CNS symptoms. Then, as you get more and more mature and more familiar, you can go on to do the more sophisticated exams, like looking at the nystagmus and seeing whether it's the peripheral nystagmus, which is unidirectional, or multidirectional nystagmus of central nystagmus. And then, as you get more experience, you can learn how to do the head impulse test, which is positive in peripheral disease, and the skew deviation test, which is positive in central disease. With that, you can be further certain about answering the second question. Then the third question, is it a first episode or recurrence? If it's first episode, then you have to think you're not very, it's more difficult. But if it's recurrent, then you have to think about recurrent diseases like migraine, BPPV, and TIA. Okay. And finally, duration is very useful because BPPV is very, very, very short. While vestibular neuronitis, migraine is long, while TIAs can be variable. Okay. So I hope when the 10 minutes past time. So I hope this 4-question approach will make things easier for you. It's not going to solve all the problems, but again, I hope I've convinced you from morning, the first lecture as well as second lecture, the moving away from gut feeling sort of diagnosis. The patient looks well, probably this, probably that, probably peripheral, probably migraine, probably tension eating. Rather than doing that, try to use a foundational formula to work through, just like you would do for any scientific pursuit, because clinical medicine is scientific. I hope I've convinced you. For the headache, use the 3-question approach to come up with a reasonable list of differential diagnoses, and depending on the probability, either admit the patient or discharge the patient. And then using the 4-question approach, coming up with a short list of diagnoses that you can decide on whether to admit the patient or manage the patient and discharge the patient. Okay. Now, this is also a medical legal implications, because these formulas, if you articulate and document that you have gone through these formulas, then even if you make a mistake, even as we always do in the cases that I gave you in the morning, all our mistakes, right? So at least you can trace back and say where you went wrong and whether it's a reasonable mistake or not. Okay. So that's how medical legal cases are also resolved. Okay. Now I'm going to wait for 5 minutes for questions. For those of you who need to go, please leave. I'm sorry I took a bit longer. I will be following up with Joyce with some notes and some additional resources for you, for those of you who want to go further in depth. But for the rest of you who just want to be sure that you understand this topic well, the notes that the Word document that I sent to you should suffice. So this is what I just sent to you, the headache profile. And if you could spend some time on the way home today just reading through this, you will reiterate your headache 3-question approach. And and your dizziness for questionable. With that, I hope you'll be able to address your patients more confidently. Thank you.
Thanks, Prof. I just have a very quick question, right? With the head impulse test,
Yes.
will it cause the patient to be violently sick if it's a peripheral, cause?
Yeah. No, actually, when you're doing the test, of course, when you do the disulfide test or doing the head thrust test, the patient, because he's symptomatic, he may not be able to tolerate the test. But the presence or absence of intolerance, that means whether you can tolerate the test, doesn't point towards one or the other. Cannot use that as a diagnostic test. But it's a real problem in the acute emergency setting. Often some of these tests may be difficult to do. That's why you realize that I've given you so many tools, right? Your kit bag has got so many tools, not just one screwdriver. If the screwdriver doesn't work, you use a hammer. Hammer doesn't work, you use a spanner. Spanner doesn't work, you use a drill. Okay, various tools to try to discern the same problem, because it is a practical problem. Sometimes the patients are so sick, you cannot do the head thrust test. So sometimes they're so sick, you cannot get the patient to sit up on the bed to do the skew deviation test. For the skew deviation test, you need to sit the patient up to see whether one eye is up, one eye is down. But if they are so dizzy, you cannot. So you cannot force the patient, so you have to abandon that test and use the other test. Likewise, the checklist of cranial nerves, you have multiple cranial nerves to do. So the advantage of this system is you have so many redundant tests. You apply some of them, you should be able to come up with some form of diagnosis. But to answer your question very quickly, the tolerance or the lack of tolerance of the test is not diagnostic.
Prof. Uma, I have a question related to posterior circulation stroke and the NIHSS score, because their scores they may be having a posterior circulation stroke, but the NIHSS score may be low. Do they then get undertreated? Just out of curiosity.
Okay, can you repeat the first part, because I couldn't hear you very well.
Oh, sorry, I will speak louder.
Yes.
Posterior circulation stroke with a low NIHSS score, because the NIHSS score is predominantly like other frontal, but not so much the posterior. Are we then undertreating this cohort of patients?
Yes, true. But the problem is that, when we are doing clinical assessment for admission and diagnosis and all that, the scoring, NIHSS scoring only tells you the severity of the stroke, right? Doesn't tell you whether it's a stroke, number one, and secondly, which part of the brain is involved. So it's a bit like Glasgow Coma Scale, right? Glasgow Coma Scale tells you how severe the patient's coma is, but doesn't tell you the prognosis of the coma or doesn't tell you the cause of the coma. So for the same reason, NIHSS score is important to do. Please continue doing it if you've been doing it, okay? But it is mostly to grade the severity of the stroke, right? Yeah, and you're absolutely spot on in saying that the main weakness is inability to grade a posterior circulation stroke well. So you will underestimate stroke. So there are ways that doctors try to address it by coming up with different scores for posterior circulation or bypassing the NIHSS and still going on with treatment, whether it's thrombolysis or double antiplatelets and things like that, based on other features of severity. But to address your question, yes, NIHSS score underestimates posterior circulation. So therefore you are likely to underestimate. But NIHSS score cannot be used to diagnose stroke. You have to be careful. Just like GCS cannot be used to diagnose the cause of coma, whether it's drug-induced coma, hypoglycemic coma, the GCS score doesn't tell you, right? It only grades the coma. So NIHSS grades the severity of stroke, but doesn't tell you stroke. That's why so far in my questioning, I didn't really specifically mention NIHSS as a diagnostic as a diagnostic checklist. But after you've made a diagnosis of stroke, you want to see how severe it is, please go ahead and do that. NIHSS. Similarly, a patient with head injury, after you've diagnosed the head injury, you want to know how severe the head injury is, you can do a GCS score.
Thank you very much, Prof. Thank you.
Okay, I'll stay on for those of you who want to ask questions, but don't worry, don't feel obliged to stay on. Please go ahead and attend your, or enjoy the weekend if you're off. But otherwise, I'll just wait a few more minutes.